So, let me start with the following. It's sort of easy to come into an established field and say, we've been wasting all this money, and everybody's so establishment oriented, and why haven't you made more progress and so on. It's kind of a fine line between being a disruptor and being a kind of critic from the sidelines who says, how could so many smart people not be doing this right? What was it that you and Michael and your colleagues saw way back when that was less about, we should be spending less on this particular treatment and more on that, but rather the kind of logic or mindset about how the science and the research was being marshaled to fight Parkinson? What was your point of view about what needed disruption at that time?
It's hard to say that we really had a blueprint or a point of view, but I do think that we brought some early principles that have continued to serve us, and even we were charting our course and we could see some clear things. And Michael, of course, had the experience of being a Parkinson's patient. I had no experience with Parkinson's disease or funding medical research, so we were pretty much newbies in terms of trying to figure out how to move the dial in funding medical research, and particularly for Parkinson's. But of course, we brought Michael and as a representative of a patient community, and it's funny. I think back to his earliest experiences, and it was really about not the typical Parkinson's patient experience, but he had a call to action to come testify before Congress and get involved, and that meant he was hearing from esteemed researchers all over the country early on about the unmet needs and what was frustrating for them, and so he was getting more of a high-level concept of what was missing, but it was really this sense that we could come in there and try to figure out and peel this onion and how could we use patient capital, bring together, consolidate philanthropy capital to start problem solving and figuring out how to do things that made more sense from the scientific point of view, and ultimately that might make more sense from the patient point of view. And so I think we had a sense of urgency that comes from a patient that when you start to look at it, and he was an entertainer and an actor. He didn't know anything about it. I had a career on Wall Street. I didn't really know anything about it. But you start to figure out, you peel this and you start to figure out what can we do, how can we do it, and do it in a way that is true to some core values of urgency, efficiency, respect for a complex situation, and how can we just use our capital to chip away at it. And it seems that our earliest lens was really one through a basic science notion, and we had to learn a lot right away. But we started to have a lot of little aha moments that really helped us think about this differently, because we weren't satisfied. As we'd say, well, what about this? And someone would say, well, you can't do that, or you must think this way. We thought, but do we really have to? And we started to just rethink impact, and rethinking impact from a scientific standpoint, and rethinking impact in terms of the patient capital and how it could behave. And I know I often am using language that really comes from my business background, but this, when you start to look at what the challenge is, it blows your mind. It's really complex, and then when you start to put numbers around it, it's daunting. And yet you think about what it must be like when a Parkinson's family or a patient finds out that they have this disease, and they go and they do what anyone would do. You go and how can I get to the best doctor, and what medications exist, and you sit back and you assume, I think most people assume when they're in touch with any disease, that there's somebody in charge of cures. There's someone who does that job. And I just now I'll Google cure for Parkinson's, and maybe Fox Foundation pops up now, but nothing would pop up for most diseases. And you realize, well, the government has some role, and pharmaceutical companies have some role, and they're actually stunning in their breadth and their size. But there is still, to this day, for the vast majority of diseases, there are over 30,000 human diseases. We have treatments for maybe 10,000 of them. There's nobody in charge of cures broadly, let alone on a disease-by-disease basis. And so, in many ways, what we've done is try to figure out, okay, you look at this massive scientific enterprise, and you look and you think you've got hundreds, over $100 billion a year spent on medical research. About a third of that is money that the government spends substantially through the National Institutes of Health, where they're funding academic research. And then you have industry. And you sit back, and even the philanthropy sector across all diseases, which is maybe a couple $2 billion, how do all these things move together, and why can't we get a better return on human health for that investment? And that's really what we've been trying to do. And it's funny, if I step back and think about how we've changed and how we've adapted to be problem solvers, it's very much been, look at this big environment, see what the patient needs are, and just start putting your money to work in the way that you can make the biggest difference.
So what I'd like to do is toggle between kind of high-level themes or insights and sort of on-the-ground stuff. So let me toggle down some on-the-ground stuff. You've been at this 7 or 8 years, whatever the time rise is. Can you tell us about 1 or 2 kind of bets you've made that you think are either the best bet you've ever made or representative of the kind of mindset you're bringing? But help us kind of visualize the sorts of stuff you're funding or betting on, so we can kind of bring this into a little focus.
I'll give you a process example and a therapeutic example. Okay. So I think one of the earliest bets that we made was to try, one of the analogies that is simplest for me to appreciate when I'm thinking about getting an idea from discovery onto the drugstore shelf is I kind of use a visual of the alphabet. I mean, it's kind of the right number of individual parts, and it's somewhat linear. It's a linear concept. If you look at the amount of money that the government spends, it's working A to D. And you have industry and moving further out the curve, perhaps where the largest capital is. Maybe R to Z. And most philanthropy dollars behave the way the National Institutes of Health behave. And so they're in that A to D, and they rely substantially on a point of view from the esteemed researchers and clinicians in the field to tell them how to put patient dollars to work the way the government puts patient dollars to work, which it's not a bad thing, but it's discovery focused. And what we really started to do is appreciate that there's lots of ideas in basic science and something like Parkinson's disease. We don't know the cause for Parkinson, so there are a lot of hypotheses about what it might be and how can we tinker away. And one of our earliest realizations was that we could bring experts together, and we still do this. It's a core part of our operation. But we would hear 10 ideas, and we might have money. Of course, we were growing, starting from scratch. But early on, we had a meeting where we had 10 ideas and we had $3 million. And in our mind, that meant we might be able to do 2 things. And the scientists, we brought folks together for a full day. And my goal as the CEO at the time was how do we get the 10 things, how do we figure out which 2 that we can do? And it was the most educational yet still frustrating experience, because at the end of the day, the scientists did not take one idea off the table. And there was this moment where you realized we can't make a decision. And it's because biology is hard. We don't know most things that we need to know to make progress in biology. And yet there are limited resources, and we have to make a tough decision about what to do next and how do you weigh all these ideas. And I realized we cannot rely on other people to tell us what to do. We have to figure it out ourselves. And we started to do something that's very uncommon in the nonprofit sector. I started to hire PhDs. We brought people on board, and they weren't a senior scientist who has there's only one Nobel laureate even close to Parkinson's, but they weren't, kind of heads of folks. We brought young PhDs in who had neuroscience training and been in a couple of years in their labs, and said, let's have our own point of view, so that they became kind of the centralized fact keepers and question askers, and that they could massage this, and it became their job to take the 10 ideas down to 2. And so this has been a real a key to us being able to figure out where to go. And what we've done is we've in that process of prioritization, what it really boiled down to is it's hard to pick out of 10 potential innovative ideas or new ideas in terms of basic science. One of the ways we ended up prioritizing is that we really wanted to ask the difference between interesting questions in science and questions that were relevant for drug development. And this ended up getting back to my alphabet. Funding was available from A to D, no problem, and it's still there. And it's one of the best investments I think the US government makes. But we fall short if we think that there's capital weighting and leadership and prioritization concepts available to get ideas that languish at D all the way to R. And that, in fact, is a real opportunity to bring the academic view and sit and spend time with companies to really understand what is it going to take to get them to invest their capital to have those ideas de-risked enough that they get interested. How do we move it?
How is that point of view sat with the kind of academic? Because you can see from an academic establishment, it's like if there are 10 options and we really don't know which is best, the scientific method, which we talked about yesterday, was you don't ask us to make judgments that we're not willing to make based on. And of course, your point of view is we have neither the time nor the budgets, or so better to move somewhere and then we go back. How is that considered controversial now, or have they kind of come over to your side of the argument in terms of their comfort level with that sort of decision making on the part of the foundation?
Well, we were running another business at the same time, which we just realized we had to raise more money. So we had to be able to fund more ideas because it is hard to tell which ones are the best. And we try to run a portfolio of things because basically all of biology is hard. And it's a high risk portfolio. And I came from Goldman Sachs and in the markets, and
they had a few high risk portfolios. Yeah. They just didn't know it at the time, but
yeah.
It's okay.
And so even the risk management training might not feel as valuable today. It is something that we use at the Fox Foundation. We're really thinking about, of all the things that we could do, let's do as many as we can, but appreciate that what can we do to discipline ourselves to think a little differently, not just about focusing on interesting questions. And part of our process and part of our strength, I think, has been to educate basic scientists to understand how we make the decision between an interesting question and a relevant question for drug development. And part of that has been to cross-fertilize between academics and industry interactions. And today we have a PhD staff of 5. They have face-to-face interactions with over 300 scientists a year, industry and academics. Our advisory board, our core group at the beginning were basically all academics, 10 folks. They're still with us. I mean, they're still smart, vibrant, essential to our process. But now our advisory board is not about setting course. Like I walked into that meeting that day and I said, what? I waited, tell me the 2 or 3 things. And they never gave me that answer. And I realized they can't set the course. And instead, today we have a 35-person panel of advisors, and they're course correctors. They're the folks that help us check our own thinking. We have this internal point of view now, and that's a mix of industry, Parkinson's expertise, non-Parkinson's expertise, academics, clinicians, as much as we can bring to the table to inform our own ability to make those asset allocation decisions and put together as many ideas to advance as many balls as we can from discovery to the clinic.
I'm reluctant to ask this because I'll quickly embarrass myself about how little I know, but is there an easy way to summarize what the foundation's point of view is about the most promising road to whether it's a cure or whatever the goal may be in terms of the science, that the routes are these 2 routes and a lot of these other routes are less promising? Is there an easy way to do that for non-biologists or no?
Well, I'll take a shot. So in Parkinson's disease, we don't know the cause. If you know the cause of something, that can really narrow your field of inquiry pretty substantially. But even in diseases where we know the explicit cause, such as Huntington's disease or cystic fibrosis, where there's a gene, of course, some things are genetic, some things are environmental, many things are believed to be some combination of those things. In Parkinson's, we have what we would, maybe 100 different hypotheses for what might cause it, and those hypotheses might translate into 100 different targets, let's say. So it's pretty hard to say which ones are most interesting, and what that path, that alphabet, that kind of progression. Part of it is kind of the concept that comes up with 100 different things that are on the table that might be. But then there's the journeyman's work to systematically take that aha discovery that this is a new concept that might be relevant for Parkinson's, and figure out, okay, which of these things can actually turn into treatments. And when you start to move things down the path, that translational research investment is really there to help you figure out which are the most promising. And the things that can build a pretty compelling case through a variety of not very sexy research, not hypothesis-driven research, not the kind of research that the government would fund for the most part, you get convinced enough and you get to the point where you have enough preclinical data that you can get big capital interested in saying, maybe there's a shot here. So today in our field, I think the biggest shift in terms of opportunity and the stuff we're most excited about are looking for the kinds of targets that could be disease modifying. So in Parkinson's disease, we have a reasonably decent symptomatic treatment for Parkinson's patients for a good portion of their symptoms, for some portion of their disease course. We have no treatment that will change the underlying course of the disease. And so a disease modifying treatment in Parkinson's would be transformative. It would be a blockbuster drug, but it's elusive. And but our best hopes today are, and the things that are closest to the clinic even, which is actually a pretty exciting time. That's not often the case where you have something that you think could be transformative and it's actually in clinical trials. Today we're looking at trying to deliver trophic factors, which I would call, kind of like fertilizer, into certain parts of the brain to reinvigorate the remaining dopamine neurons that might be able to kind of sustain themselves and start providing that chemical so that movement can be restored. If we can deliver those trophic factors or these growth factors, they're also called, and get them to the right part of the brain, that's exciting. And it's both, do you have the right factor that you want to put into the brain, and how are you going to get it there? Delivery is a big challenge. But some of these things are in phase 2 clinical trials, and we're going to get some answers in the coming months on the one that's probably closest. But I have to say that portfolio part of me and our team, we have investments in things that are a while back, kind of more different types of trophic factors, and we have a lot of different investments thinking of alternative delivery strategies, because the chances are that something works are still pretty low, and so we keep working on those fronts.
Let's stay with the granules. You said you were going to talk about a process thing, which you just did. Was there a particular project that, the most exciting thing you've ever done, the best thing, or whatever, use whatever qualifier you want, but an investment you've made that you think shows the promise of this way of doing philanthropy?
I think I'll talk about this thing that's in phase 2 clinical trials now. For one, we've by the end of this year we'll have funded about $150 million in research, and our focus is only in research. We don't provide any direct services to patients. And about 30% of that money has gone to companies, which is a little bit different point of view. Most nonprofit disease organizations are providing direct services, and if they do any research, they tend to be focused on academic research and basic science. One of the things that we've realized is that this use of our capital, which is different than how the government uses capital. Government looks at science for science sake, and researchers in academic settings are rewarded for paper generation, and they want tenure, and they're building a lifetime of knowledge, and it's lots of incremental findings. And in industry, you have this concept of return on investment, big market. How am I going to recoup this $1 billion that I've spent in 5 to 15 years to get to capitalize on this new finding? We look at our capital and say we want to de-risk the ideas. We want to figure out which are the most relevant to move to the clinic and tee things up for somebody else to develop. The Fox Foundation is never going to take anything over the goal line. So what we have been doing more and more of, and hope that we'll have increased opportunities to do so, is find ideas that are just about to go into the clinic and use our capital to help make those early stage clinical trials more robust. So in this example, Serogene, which is a company in San Diego, had this idea. They had the growth factor, and they also had a delivery strategy, a gene therapy delivery strategy. And our research team had interacted with these guys at Neuroscience, I suspect. So they'd come down to kick the tires and hear more about what they're doing, and we invited them, come tell us about how we could add some money to your clinical trial. And because they were just about to go into a phase 1 trial. They had investors, their venture capitalists had provided $4 million for their phase 1 trial going into 12 patients to determine safety. But of course, you really have to peek and get some information about efficacy to figure out if you should make your next investment. Pretty much everything in phase 1 clinical trials in Parkinson's disease works. You need to go to a double-blind placebo-controlled trial. So these guys had a $4 million trial that was FDA approved and backed with their venture capital, but they came to us and said, and we asked, what could we do to make this a little better? Because the venture capitalists are going to fund a lot of things, not fully. And so we gave them $750,000 to give every patient at one additional doctor visit more data. And we gave them the money also to do their neuroimaging, more data. You had to figure out if this delivery if the drug was getting where you intended it to go. And that started a partnership with them. 12 months later, they had pretty good data in those 12 patients, and they were working on their phase 2 trial, a $10 million trial. Now their venture capitalists are more excited. We come in and we put $2 million into the phase 2 trial, maintaining the neuroimaging, increasing the number of patients they could see, and we paid, kind of patient-centric, motivated, I guess. We paid for a crossover if someone was not getting the drug because they were in the placebo group and it worked. Right. We wanted to pay for them to have access to the drug, and that, of course, wasn't on the venture capital list. And so, ultimately, now this is in phase 2 trials. They've relicensed this program to Genzyme, so they have a $125 million partner behind us. We probably will never have to make another cash investment if it's working because it's on its way. But it's exciting for us to use our capital that way, and the actual treatment has high potential.
I don't know if it's a weird question or a good question, but is that, in a way, a tough sell to funders? Does it require a mind, in the following sense? We heard Jackie yesterday, tell that incredible story about the Kenyan marketplace. And so you go to people and say, we want to rebuild a Kenyan marketplace. We've got Dennis and his students there, and who wouldn't want to be supportive of that? And then you go to funders and say, we want to give money to a drug company. It's not, it's not really what people are lying awake at night dreaming about as a philanthropist, saying, I want to help a drug company be. But on the merits though, it makes, so does that in a way? It ends up
that this is another area where we don't really look like very many other folks.
That's right.
So we have 25,000 donors at the Fox Foundation in a year. But I work with, I can tell you in almost every year, these numbers are pretty consistent, and I've never seen them anywhere else because I've been looking. We have 40 to 50 people out of 25,000 who are giving $100,000 or more, and most of them pretty consistently. After their first gift, they just keep doing it, and it keeps going up. And these are philanthropists, and these are folks who are looking at this saying, this is where my money can actually move the dial.
Right.
Because they see that this concept of our capital, this patient capital, of de-risking the ideas for the ultimate investment is actually the only way you're going to get something to the drugstore. Right. The Fox Foundation in an academic lab is not creating a drug. It's the first step or the third step in a step that requires an extraordinary amount of serendipity to get anywhere close to the patient. So this is actually fundamentally an area where philanthropists look at this and say, if my alternative is to, out of gratefulness to my doctor, write a check because they're an esteemed doctor at an esteemed institution and feel good, that's one option. But what I find is folks who are trying to move the dial in medical research actually are extremely attracted to this and are, if you follow the money in terms of the kind of people who are buying into this as a way to actually fund research with impact in mind, it's a really exciting new opportunity, and it's actually one of the things I think we're getting to be known for the most.
That's great. I want to end, I got the time. Let me end on a question that is probably a ridiculous question, and with totally unfair to ask it to you, but what the hell, let's do it. So I was out at Eli Lilly a while back, great people there, but they feel, as a major pharmaceutical company, that they are really in crisis. Yeah. Well, that's funny you say that, because the first slide they showed me was, we want to show you America's trust in various institutions in society. And at the very bottom is Congress, which always seems to come in the right? One above Congress are the tobacco companies. So Congress is actually more dangerous to your health than smoking cigarettes. But right above the tobacco companies are the pharmaceutical companies. Now, it is really, and I'm not here carrying a brief for the pharmaceutical, but it is amazing, and it just shows you how mixed up that there's companies who are in the business to kill you, and those are the tobacco companies, and they're just a notch below companies who in some sense exist to save you. Yeah. And now, they either deserve that or they're misunderstood, take it what you will. What is your, what is your sense of a disruptive philanthropist who needs to interact with how big a crisis the American pharmaceutical business is in terms of whether it's, and I tell you, it's like, you have 30 seconds to answer, this is ridiculous, but it's the McLaughlin Group. On a scale of 1 to 10, how big are you? But, it does seem like this is an industry that is just in such crisis in terms of its business model as it's been practiced for the last 50 years, and our societal unwillingness to sort of keep going about it that way. So do you have any last minute thoughts about just where the pharmaceutical business is today, given how important it is to all of us, and where it's got to go?
I think the pharmaceutical companies, from my vantage point, you can see from a capital trend, they really moved towards being in the business of buying a phase 3 idea.
Right.
So, and they can take a phase 3 idea and they can use their strengths in regulatory relationships and manufacturing and distributing drugs. And so what you see is they've outsourced a lot of the earlier stage things to biotechs, and so they buy ideas from biotech companies. But there's still a pretty big disconnect, because a lot of biotechs can't get money. A lot of our money is going to biotech companies that are ultimately going to be bought by somebody else.
Sure.
But at the end of the day, what you find is it's still a pretty significant disconnect for anybody who has capital who's trying to find that right idea to figure out the ones that are going to work. And my view is that more money spent earlier to ask a thoughtful question and a relevant question is going to really save investment at the other end. And this concept that it takes 15 to 20 years to develop a drug and it costs $1 billion, whatever, whoever's numbers you use, $750 million to $1.5 billion to develop a drug, part of that is all the things that don't succeed. And I think we could be redirecting capital for earlier questions that will help take some things off the table and might make the process more efficient. And you asked about, what's it like to try to give money to companies, and we give money to a lot of small companies. We gave $1 million to Wyeth. Now, when I went to the board with that one, there was a little, we know how hard it is to raise the money. I can tell you how hard it is to raise the money. But we launched an entire program within Wyeth that didn't exist before. Our $1 million cash turned into a $15 million in-kind investment, and now it's in the hands where it can run over the goal line by itself. But another way where we're working with companies, and I think it gets to this, is that companies realize they can't afford to, and don't have the bandwidth really to establish the earliest stage ideas on every disease that they might be interested in, let alone where they have assets like compounds or a technology platform. And so in the last couple of years, we've started some new ways of working with companies where, and we just announced, we had a press release yesterday on some of the outcomes of this. Elan Pharmaceuticals and EMD Serrano are two companies where, with different intent, they basically look at us as an expert to outsource early stage discovery for them. So we know more about the Parkinson's research field than anyone else in the world. We don't know everything, but we know more than anybody else. We sit at that nexus of activity. We're the largest funder besides the US government, but we're funding applied work, and we have this lens of relevant questions, not just interesting questions. And this makes us a really a consolidated point of view around what are the best sets of ideas. And this notion that Elan and EMD in two different examples gave us a couple $1 million to just basically do the work at a stage that they don't want to do and can't do internally. And if one thing comes out of 10 of those grants, they think that's a home run. And by the way, their $2 million in our hands is far more levered than it would be in their internal hands. And so these are new ideas and new ways to kind of bridge this gap, and just looking for better ways to move high-risk activities with impact in mind, and get these ideas over a tough pathway, but in a more directed sense to impact patients. And I think that's where we've tried the hardest to, we haven't been satisfied, and we keep trying to ask the key questions on how can we do this in a different way that can be more relevant for patients.
Fantastic. Well, look, best of luck in your work. Thank you very much. Debbie Brooks.